interested in, especially in biological psychiatry. We always have a speaker who is of reputation and who has a lot of research behind his back for deliberating upon the topics and interacting with the delegates during and after the session. And we have worthy chairpersons who have also earned their name in the field of mental health. And other than that, we have the people behind all this who have made it successful and who have actually conceptualized it. Starting from Dr. U.C. Garg, right now we have Dr. Sunil Mittal sir, who is from Delhi and a very well-known psychiatrist of our country. Then Dr. Rukshida Saida, who is the Vice President of Indian Association of Biological Psychiatry, who is again with us. We have a very important topic to deliberate upon today, which will be, I think, taken over by Dr. Nishant, who is our chairperson from CIT Ranchi, and Dr. Hina. May I request Dr. Rukshida Saida to take over from here and continue with the proceedings. And I welcome all the delegates right now who are on the panel. And I'm sure that keeping in view expertise of my dear friend and a teacher, like I would say a teacher friend, Dr. Sandeep Grover, who doesn't need an introduction at all, will be benefited by this today's session as well. Dr. Rukshida, please continue.
Thank you, Dr. Majid. Good evening, everyone. It's my pleasure as the Vice President of Indian Association of Biological Psychiatry to welcome you all today and just give you an introduction of our First Friday CME series. We're in our third year now. It's an open access series, it's a curated series, and it's a niche series where we're only talking about biological psychiatry, the clinical aspects, and anything related to biology. And we're very, very honored today to have our president, Dr. Sunil Mittal sir, who's joined us today, and I request him to share a few welcoming remarks.
Thank you, Rukshida. It's a great start to the new year. And like I was mentioning, it's a great start by having stalwarts in psychiatry conducting the CME, speaking. We have Dr. Sandeep Grover speaking, Dr. Nishant chairing. You can't get better people. So this is going to be a great start to a new year for the Indian Association of Biological Psychiatry, which is committed to biological psychiatry. And this CME is very, very popular. It's live streamed. As you can see, there are 56 participants already at 8 o'clock sharp. And it's being live streamed on YouTube, and it reaches hundreds of people. And then since it's available as a resource on YouTube, at our center, my students and other colleagues, they access it and they view it again and again. And every time they hear it and they see it, they find a new pearl of wisdom. So having said this series this year, I'm sure should be exciting. Back to you, Rukshida.
Thank you so much, sir. And we're always very, very grateful to our faculty because they're all contributing and volunteering their time, effort, but most especially their knowledge. With this, it is a pleasure for me to introduce the chairs of today. We have none other than Dr. Hina Merchant, Pandit Merchant. She's a friend. She's also my president of Bombay Psychiatric Society. She's an associate professor at Sion Medical College, which is my alma mater. She's a never say die attitude. And I think with the recent campaigning, there's nobody left in the Indian Psychiatric Society, at least, who doesn't know her and recognize her. And she's full of energy and can talk a mile a minute. Having said that, she's always rational. So that's one of the major reasons that she's our pick of the chair of the first session of this year. So welcome, Dr. Hina. It's really lovely to have you with us, and we are honored that you agreed to join us today. It is now my pleasure to introduce the second chair. He's homegrown because he is the honorary treasurer of Indian Association of Biological Psychiatry. And of course, I think everybody who wants to do anything in kind of somatic therapies, we all know Nishant is the person to go to. So Dr. Nishant Goel is a wonderful teacher. I think his never-ending list of research and publications and contributions to chapters is just the tip of the knowledge that we know that he has. And he's always very, very approachable, very friendly, and very helpful to all students and colleagues alike. So we're especially grateful to him for joining us and agreeing to chair such an important topic. That still kind of is a conundrum, and it's something that all of us, whether we are just young students learning psychiatry today or stalwarts with decades of practice behind us, still need to learn about. So with this, it is my pleasure to hand over to the chairs to take the session forward. Thank you so much.
Okay. So before I request Dr. Hina to introduce our speaker, just a couple of words regarding today's topic. I think it's been 1988, if I remember correctly, when John Kane first talked about treatment-resistant schizophrenia. And we have come a long way. And now that we are talking about clozapine-resistant schizophrenia, and I'm sure a lot has happened over the period of time. A lot of research has happened. A lot of new avenues have opened up when it comes to managing difficult patients with schizophrenia, where after even giving clozapine, we are still at loss. We don't know what to do. And I will not take much of time because every one of us, we are dying to listen to Sandeep Bose. Not only that, he's an erudite speaker who will be, introduced by Dr. Hina, but I think he has the maximum number of publications when it comes to, using clozapine. And if you just see his list of publication on clozapine, it is mind-boggling. And he's been always after me ki chalo kuch karte hain, let us do something. And I have been after him, to work something related to use of clozapine in adolescent population. And I wish that today's talk will definitely gives us more insight into managing difficult patients whom we are at loss even after giving clozapine. With these words, I request Dr. Hina to kindly introduce our speaker. Over to you, Dr. Hina. Thank you.
Thank you, Dr. Nishant. At the outset, I would like to thank Rukshida, Dr. Mittal, and the entire team of IABP for giving me this opportunity to chair this session. Well, I've been given the task to introduce Dr. Grover. I will just say one thing. Is there anybody in the country who does not know who Dr. Grover is? But well, for all those who still do not know, I would still say a few sentences about Sir. Sir is the professor at the Postgraduate Institute of Medical Education and Research at Chandigarh. He's also currently the editor of the Indian Association of the Geriatric Mental Health. As Dr. Nishant said, that he has n number of publications, and I have Google open here on my other phone, and it says that Sir has 1,014 publications with 283,743 reads and 16,171 citations. I think Dr. Grover, I think there cannot be a better introduction to you than this. This is straight coming from Google. So without much ado, it is indeed our honor and pleasure to listen to you on this very important topic. So over to you, sir.
Yeah, thank you, the office bearers of IABP and the chairpersons, and I wish everyone here a very happy new year. And let's start the talk with that note. Is my screen visible?
Just
not yet.
It's just starting.
Is it visible now?
Yes.
So what I'm going to talk today is about assessment and management of clozapine-resistant schizophrenia. We all understand treatment-resistant schizophrenia, but I'm taking the matter to a step beyond that. So let's try to understand what we want to discuss. So we all know that antipsychotics are the mainstay of treatment for schizophrenia. You cannot manage any patients of schizophrenia without antipsychotic. That's something which we all know. But the fact which we need to remember is about 30% of patients with schizophrenia do not respond to 2 adequate trials of antipsychotics, and they are considered to have treatment-resistant schizophrenia. And in these patients, clozapine is the drug of choice. And because of clozapine being the gold standard, it comes as an antipsychotic which is expected to improve patients who are not responding to other antipsychotics. But unfortunately, what happens is about 30 to 70% of patients with treatment-resistant schizophrenia, despite we using adequate clozapine trial in a monotherapy, do not respond to the same. So this is what we need to understand are people known as clozapine non-responders, clozapine resistant, ultra-resistant, or super-refractory schizophrenia. They are considered to be the most severe kind of patients with schizophrenia. And overall, if you look at different percentages, about 10% of schizophrenia will fall into the category of clozapine-resistant schizophrenia. So when we look at the definition and the concept of clozapine-resistant schizophrenia, as Dr. Nishan said in 1988, when John Kane first defined TRS to get back clozapine into the market, that was the first attempt. But when clozapine was not working in certain patients, everybody tried to define clozapine-resistant schizophrenia. And the basic difference, many basic facts which came into the different definitions were that a person was not responded to clozapine of 4 to 12 months trial. But later on, people started saying that 6 to 12 weeks of trial may be enough. The other issue which came into fact was the clozapine levels about more than 350 to 450 nanograms per ml. And in terms of response, again, for normally we talk about 50% reduction, but for TRS and CRS, we talk about reduction in about 20 to 50% reduction in the standardized scales, and no stable period of functioning for last 5 years. This is what the different components, this is not part of any proper one definition. The first proper definition was given by Mockfook in 2006 when they first tried to review the literature, and they looked into the literature on clozapine-resistant schizophrenia. And they said that one of the major limitations in understanding clozapine-resistant schizophrenia is the methodological heterogeneity in the literature, lack of standardized criteria to define clozapine-refractory schizophrenia or the ultra-resistant schizophrenia. So what they defined it for the first time, that a clozapine refractory condition is considered to be at least a person who has received at least 8 weeks treatment with clozapine with a therapeutic level of 350 microgram per liter, and there is failure to improve by at least 20% on the BPRS. So this is something from where the definition starts, that at least 8 weeks of clozapine and less than 20% improvement. Then there is the presence of persistent positive psychotic symptoms. And then they define the severity in terms of how much the BPRS score should be more than 45 or a score of more than 4 on the CGI, and no good functioning in last 5 years. That is how the definition started in 2006. The next major landmark came in 2017 when the treatment-resistant schizophrenia, that is the treatment response and resistance in psychosis working group from USA, tried to develop the concept of TRS and CRS. And this definition basically included, first let's try to understand how it defines treatment-resistant schizophrenia, that a person should have received at least 12 weeks of antipsychotic, that is 2 adequate trials of antipsychotic, that is 6 weeks each, and that we need to remember in the doses of more than 600 milligram of chlorpromazine equivalent. And when we talk about this 6 week trial, thing to remember is the maximum tolerable dose. It's not the 6 week antipsychotic trial. That is something which many times we fail to understand. So we need to emphasize that this is the maximum tolerable dose given for 6 weeks. The medication adherence has to be about more than 80%, and there should be moderate severity of symptoms on a standardized rating scale, and there should be moderate level of functional impairment. That's how the treatment-resistant schizophrenia was defined. So how do we define clozapine resistant? Somebody who fulfills the criteria of treatment-resistant schizophrenia and there's a failure of clozapine. So let's now try to understand how the TRIP definition talks about the clozapine failure. So here they first try to define in 2017 that there should be at least 3 months after attaining the therapeutic plasma clozapine levels of more than 350 nanograms, during which the criteria of treatment resistance have persisted. So when we say criteria of treatment resistance have persisted, means there is less than 20% improvement in the symptoms, adherence is more than 80%, and also the SOFA scores are less than 60%. So this is what you need to understand, that positive symptoms are persisting from that perspective. However, when we look at this so-called definition of clozapine resistant and clozapine non-responders, here they talked about 3 months criteria. But later on, again, this Wagner, which also talks about the same TRIP survey, which was another survey which was conducted later to understand CRS better, they talked it slightly differently. They try to refine the criteria based on the various factors. One includes that is the duration of trial. And while considering the duration of trial, they did not homogenize as 3 months. They talked about various symptom domains as positive symptoms, negative symptoms, cognitive symptoms, sociality, aggression, and mixed symptoms. and then they try to define the trial duration. The longest trial is required for patients who are having treatment-resistant negative and cognitive symptoms, which is for 4 months. Intermediate trial is required, that is of 3 months for positive and mixed symptoms, and a shorter trial of aggression and suicidality, which is of 8 weeks. So if you understand now, the concept is changing. We are not just talking about, if you understand the TRIP definition of TRS, again, we have positive symptom TRS, negative symptom TRS, and cognitive symptom TRS, and a mixed symptoms TRS. So similarly, CRS again, the trial duration has varied depending on the symptom domain. That's something which we need to first understand. Then they talk about getting the clozapine levels done, and they should this includes at least 12 weeks trial after attaining 350 nanogram per ml. So that is one which you need to understand after it has been attained. So the trial, how much time you take to attain that 350 nanogram is irrespective. Don't consider that period. Once you have achieved 350, then talk about that. And the clozapine level should be done on at least 2 occasions, 1 to 2 weeks apart after you have achieved 350. And the levels should be done without giving an advance notice to the patient, because if you give an advance notice to the patient, his medication adherence may improve and you may get a false kind of thing that patient is actually taking medication. So no advance notice to be given. And it further says that if it's not possible to get the clozapine levels, a dose of about 500 milligram per day is recommended before you say that patient is having clozapine resistant schizophrenia. However, in terms of medication adherence, the same 80% criteria persist. What they assess that at least 2 methods should be used to assess adherence, which includes patient and caregiver report, or the dispensing chart report, and pill count. So in Indian setting, we can use pill count and the patient and caregiver report. But what the criteria again specifies, you should not only rely on the patient report. That's something again which we need to remember. And in terms of symptom severity, again, say moderate severity is what is required. And again, in terms of symptom persistent, again, as we have talked about positive symptom, negative symptom, cognitive symptoms, defining CRS. So similarly, you have to remember more than 2 symptoms present for at least moderate severity. So 2 positive symptoms of moderate severity, we talk about positive CRS, 2 negative symptoms of moderate severity, we are talking about negative CRS. So that is where this positive negative CRS will now have its own connotation in defining the treatment later on, which we'll discuss later. So what are the problems in this definition? The basic problem is of assessing clozapine plasma levels, which is not very freely available in poor countries like India. In India, we have only clozapine levels in very few metros or few institutes. So clinicians have to use their clinical decision to decide when there is a clozapine failure. So the practical definition is try to the maximum tolerable dose for at least 3 months before you say that clozapine has failed and you need to augment it. But we need to understand for Asian patient, the minimum dose which is required to reach to 350 nanogram, which this is what the De Leon group has proposed. This is an international adult guidelines for clozapine titration and how the clozapine doses will vary depending on the ancestry. And for the Asian and original American patients, it has been said that if the patient female non-smoker, the minimum dose which is required is 175, male non-smoker but 225, and for male female smoker 300 milligram per day. So this is the minimum dose which you should consider giving the patient before you say that clozapine has failed. With this understanding about the concept, now let's move to the assessment part, because we all understood the definition part of CRS. So the first thing to do is rule out a pseudo-resistance, and for that we have 2 broad schemes in the literature. Let's just try to understand what the TRIP group says. They say that evaluate the factors which can lead to pseudo-resistance is poor adherence, inadequate doses, or suboptimal plasma levels due to either the enzyme metabolism or drug interactions, presence of comorbid medical condition which may actually be mimicking the poor response, but actually patient may be responding, or comorbid substance abuse, which can influence the medication adherence or can influence the clozapine levels, or presence of any organic condition which has been missed and it has been wrongly diagnosed as schizophrenia. The second scheme which you need to remember is the 5 C's, which is important and for us to understand, easier to remember. First C stands for making a correct diagnosis, looking for comorbid condition, looking for compliance, looking for concentration of the antipsychotic, and looking for the continuous psychosocial stressor. Correct diagnosis basically means that when you are thinking about, initially you have diagnosed that patient with schizophrenia or treatment-resistant schizophrenia, but many times patient with severe personality disorder, mania, or something like chronic mania, or patient with chronic depression with psychotic symptoms are labeled as having TRS and CRS. So that needs to be kept in mind, and you need to review your diagnosis. Always remember to rule out NMD encephalitis properly from the history and other investigations if required when the patient is not responding to clozapine. So this will allow you to determine other treatable causes of patient's condition, and also possibly help you in choosing an augmenting agent if you want to continue with clozapine. In terms of comorbid conditions, substance use, affective disorders, OCD, personality disorders, again, these are again very, very important, because this can again influence what medication you're going to use for augmentation for clozapine. And the compliance issue has already been emphasized in the CRS definition, but we need to understand when we're talking about poor compliance, you need to understand what are the factors which influence adherence to the medication. And this basically includes substance abuse, hostility, lack of insight, but it does not stop here. The compliance can be influenced, or the patient may have non-adherence either because of the different reasons which needs to be understood, which could include again incorrect diagnosis, use of unnecessary medication changes. In India, we see that it's the tendency that we usually don't give an adequate trial, and the drugs are changed much faster. And that makes it very complicated for us to understand whether the patient has received adequate trials or not. And that's why you're not able to determine. And then at times you end up doing prospective trials so that you're very sure that patient has CRS or TRS. And other illness factors, or the physician or the service related factors, the caregiver factors, needs to be ruled out when you're evaluating the compliance with the medications. I'm not reading each and everything, but I'm hoping that all of us are aware of that. And similarly, the past history of adherence, the attitude towards medication, stigma, and the medication related factors like effectiveness, side effect, dose frequency, all needs to be looked at before we say that patient is being adherent to the medication. And in terms of assessing the medication adherence, we need to understand that there are different methods which can include interviewing the patient, looking at the patient diary, using adherence questionnaire. But we need to understand using multiple methods together can help you in better assessment of medication adherence. So TRIP definition, which I have already mentioned, I'm not repeating it here, but you need to understand you should not rely only on the patient report and use at least 2 methods to determine the compliance. And there should be at least more than 80% adherence to the prescribed doses of medication. Then there are continuous psychosocial stressors which can lead to worsening of illness, and this can include poor housing, poor social support, isolation, poverty, or the caregiver issues like caregiver burden, express emotion, stigma, poverty, which needs to be considered while you evaluating the psychosocial stressors, because taking care of this may actually influence the patient's environment and lead to improvement in psychopathology. In terms of concentration of antipsychotic, again, just mentioning this 350 to 600 nanogram gram per ml, but 350 is the minimum which we need to remember. And when we are doing this, you need to remember a trial of at least 3 to 6 months. Some people say you need to understand that when you are talking about the concentration of medication. So finally, to conclude, that before we consider somebody is having clozapine resistant schizophrenia, we need to confirm the diagnosis of schizophrenia, confirm that the patient has received an adequate trial of clozapine in terms of dose, duration, serum level, and adherence. And also we need to understand which symptom domain we are considering as CRS. Is it positive domain, negative domain, cognitive, aggressive, suicidal, affective, or so on. So because this will determine what medications we are going to choose, because the available evidence is very, very small for this. So once we are sure that we are dealing with clozapine resistant schizophrenia, let's look at what we can do for augmentation. The first fact which we need to remember, that if patient has failed to clozapine, the first fact to remember, don't change clozapine. Clozapine has to be continued. You are just going to do augmentation. For when somebody doesn't respond to clozapine, there is no choice of changing antipsychotic until the person is not tolerating clozapine for some other reason. So what are the treatment options which we have? Are the various pharmacological agents, electroconvulsive therapy, RTMS, TDCS, and various psychosocial intervention. When I am talking about RTMS and TDCS, I hope Dr. Nishant will make us more wiser about it. When we talk about the pharmacological agent, you can use a second generation antipsychotic, antidepressant, mood stabilizers, or the other agent. So when we look at the evidence, there are 2 kinds of evidence which is there in the literature. One is the data coming from different studies, and second is the expert consensus opinion, because that is also very, very important in this kind of a condition, because you cannot do different kind of trials, because in all centers you will not have sufficient number of patients. So when we look at the evidence base, again, there are very few RCTs, lot of open label studies, and lot of meta-analysis, surprisingly, because the data is smaller, so a lot of people have tried to do the meta-analysis. So when we look at the antipsychotic, can we augment a patient with second antipsychotic who is not responding to clozapine? So there are different RCTs and open label studies which have evaluated the whole list of antipsychotic which I have listed here. What is the evidence? What we need to understand? The data was recently reviewed by one of my colleagues from the department, Dr. Shubho Chakrabarti, and in fact, he did not review independent studies, but he reviewed 12 reviews and systematic reviews and meta-analysis. And what is the conclusion? That the evidence is inconclusive, and adding a second antipsychotic has no much benefit. That's what we need to understand. And this is what we had reviewed about a couple of years back, and this has been updated. So if you see the number of trials, the maximum number of trials which have been done is for risperidone, followed by aripiprazole and amisulpride. The maximum number of positive trials are for amisulpride, followed by risperidone, when I'm talking about the RCTs. But overall, if you look at the sample size of these trials, sample size are very small, and most of these trials have less than 40 patients, so it becomes very difficult to make a conclusion. This review was again done in 2019, which again look at the data, and this review has maximum number of data coming from 12 RCTs for amisulpride, aripiprazole, risperidone, ziprasidone, and they again say that SGA do not improve positive symptoms. Our executive SGA can lead to small improvement in negative and depressive symptoms. So this is what we need to understand, because as I said, when you're talking about CRS for positive symptoms, adding a second antipsychotic may not be a good choice. When we talk about the evidence coming from various RCTs. Then multiple antidepressants have also been assessed for augmenting CRS. And again, if you look at that, there are at least 4 meta-analyses in which you see the agents which have been used, like something like various SSRIs and SNRIs and NASA. And what is the evidence for this? Again, no much benefit. So we need to again understand that no much benefit is being talked about for positive symptoms, but for there's some evidence for maybe they may work for patient with negative CRS. And in terms of various mood stabilizers, again, valproate, lamotrigine, topiramate has been evaluated. The good thing here to understand that there's some evidence to support lamotrigine, valproate, and topiramate. So it becomes important when we need to understand the topiramate, because it may also help you in reducing the weight, which is a major concern with clozapine. In terms of other agents which have been used are something like memantine, donepezil, glycine, serine, sarcosin, but again, very small number of trials against very small sample size. So there is a lot of bias about publication towards positive studies, and other agents which have also been tried, again, the same problem remains, that the sample size is small and there is bias towards publication of positive studies. Now, coming to the important armamentarium, which is again ECT, which is available in India freely, and it is used by psychiatrists in India much before other agents. In fact, sometimes we use ECT in the first episode, schizophrenia also. So what is the data for use of ECT in patients with CRS? Unfortunately, most of the data is again in the form of retrospective studies, open label studies, and case series. And only one well-conducted randomized control trial is there from USA. And there are a lot of systematic reviews and meta-analysis. So the Petri et al. Trial, which was published in 2015 from USA, they compared ECT plus clozapine versus only clozapine, and what they showed that people show 50% of the treatment group showed at least 40% response when you combine ECT plus clozapine. And when in the crossover phase, when those were not who were only on clozapine, they were again added, ECT was added, 47% showed response. That means ECT is always useful in patients who do not respond to clozapine alone. There are other reviews. This was done by Lally et al. In 2016. And again, what they suggest that when the data is taken from open label studies and RCT, the overall response rate is 54%. When we take data from all kind of studies, it is 66%. And overall, during the follow-up rate, the relapse rate is low. That is about 32% people relapse. But you need to understand the longer duration of follow-up. Here, they are talking about 3 to 4 days, 68 weeks of follow-up. And the adverse events are reported in only very few patients, for those who are on ECTs. This review, which came from basically China, and which also include most of the studies from China. It reports a data of about close to 1,800 patients. Out of the 18 RCTs, only one, which is Pettit et al., rest 17 are from China. So I leave it to your wisdom about how do you look at that. But what does this again suggest? That use of adjunctive ECT in patients who are not responding to clozapine, they have better response rate at post-ECT assessment and also at the endpoint assessment, both in terms of response and remission. So again, there is nothing negative towards ECT from whatever data we are looking at. Again, the side effects rate, memory impairment, and headache are seen more commonly in patients with ECT. This is what we all know. But we need to remember data is coming from China. This is a study which we conducted at our institute, where we compared patients with CRS and non-CRS. And when we talk about response rate of more than 40%, 48% showed response in the positive symptoms, 25% showed response in the negative symptoms. And in general psychopathology, again, about 47% showed response. And in depression, again, 45% patients responded. So this is what, again, I would say that adding ECT into patient with any symptom domain may be useful. When it comes to RTMS, again, we have only limited number of studies. What I could lay hand to is 4 studies which are available, out of which 2 showed benefit. And in terms of one meta-analysis which is available, which included data from 3 RCTs, but the number of patients totally is about 54, which with 26 patients on RTMS arm and 28 on the sham arm. No significant difference between RTMS and sham in terms of total positive or negative symptoms. So RTMS, we do not have much data to support. In terms of TDCS, again, we have few trials, one 4-week sham trial in which they evaluated the PANS, matrix, and also the auditory hallucinations and other things. And they were randomized to, again, sham and active TDCS. Again, what we see that TDCS leads to some improvement in auditory hallucination, but the difference is not much significant. And in terms of cognitive function, there is some improvement in working memory, but no improvement in other cognitive domains. So that is where what we have data for the TDCS. And this again, another small trial which included data of 5 days trial. This also did not show much benefit with TDCS. Now coming to the another important intervention, which is psychosocial intervention, we have a lot of trials here, and they show that there is reasonable level of benefit in patient with clozapine-resistant schizophrenia when you combine clozapine with psychosocial intervention, something like cognitive behavior therapy or occupational therapy. However, this major big trial, which came from UK, which included data for about 250 patients in each arm. If you look at about 500 patients, this failed to show any benefit in the primary outcome of this trial. So this was a failed trial, and this actually influences the whole systematic meta-analysis and review, because this has the largest sample size, and that's why whatever we have now is that primary outcome with is not significantly altered by the psychotic CBT. And so in terms of secondary outcome, there's some improvement in the positive symptoms, but not much improvement in the negative symptoms. That's what, again, we need to understand. So how do we go about? These are, now I'm going to share a few reviews which have looked at all the data, and they have tried to formulate how things should be considered. So the first review in this direction was by Wagner et al., who reviewed all the data, and they try to grade the evidence in the terms of +1 to +4, the least so-called list weightage was given to the expert opinion, and those with high quality meta-analysis were graded as +1++. And then the gradation was again done in terms of A, B, C, D. So when we look at this data, what we have? For positive symptoms, there is no grade 1, grade A evidence. In terms of grade B evidence, you have for positive, you can use ECT or combine it with second antipsychotic or fluoxetine. And the other choices are again valproate, lithium, lamotrigine, topiramate, or RTMS. And if the last lower grade is for glutamatergic agents, TDCS and CBT. In terms of negative symptoms, again, this data which comes from 21 meta-analysis, and we did a network meta-analysis here. So the grade B evidence for, again, antipsychotic, fluoxetine, duloxetine, citalopram, lamotrigine, topiramate, RTMS at grade 3 C and D, and the lowest for glutamatergic drug, TDCS and CBT. In terms of the other so-called meta-analysis and network meta-analysis, this was done by Ye et al. In 2023, the most recent one. They included data from 35 RCTs, and the data pertained to about 1,500 patients with 23 active augmentation treatment which were compared. So what we have, the three agents which stand out is mirtazapine, electroconvulsive therapy, and memantine, which may be of benefit for positive symptoms, ECT, for negative symptoms, memantine and mirtazapine. Other all antipsychotics and other things not of much benefit. Among the antipsychotic, only thing which you need to consider if you want to choose, amisulpride has the least discontinuation rates. That's where you need to keep in mind. Now we come to the expert consensus recommendation, which comes from the TRIP group, because they carried out the people who have expertise in managing patient with CRS and TRS. And this survey included about 49 psychiatrists from USA and other parts of the world. They evaluated how we need to go about. And what they said, they gave the different clinical status of the patient, and they asked them to choose 5 most effective treatment options from the given list. So when we look at what are the things which have to be done, what was the general recommendation first? The consensus recommendation was leave the clozapine dose as same as which you are using monotherapy. Don't reduce or don't stop clozapine. These were the two general recommendation. And in terms of management strategies, because if you want to remember, this is one table which I'll ask everybody to remember. Positive symptoms, negative symptoms, mixed symptoms, or there is no improvement or worsening on clozapine, or clozapine refractive schizophrenia, or clozapine suicidality or aggression. Number 1, ensure that clozapine levels are more than 350 and you are given that 3-month or 2-month or 4 months trial. For positive symptoms, what they recommend is use a second antipsychotic, because again, we need to remember this data comes from the Western world where there's a lot of stigma with ECT. That's why ECT comes at number 5. But when we look at evidence, ECT possibly comes after clozapine levels of 350 is number 2. In terms of negative symptoms, again, non-antipsychotic augmentation should be considered, which basically includes antidepressant, which can include mirtazapine as one of the choices. For mixed symptoms, almost similar kind of things as you use for positive, but with some evidence, some weightage is given to the use of psychosocial intervention. And same for the mixed symptom. However, when there is no improvement, again, if you look at that, they are not recommending ECT here. And in terms of suicidality, you will see that antidepressant comes as number 1, mood stabilizer as number 2, and ECT as number 3. For aggression, second antipsychotic comes as number 1, mood stabilizer as number 2, ECT as number 3, and antidepressant as number 4. But in Indian settings, I would say that when I talk to my colleagues and who we all are managing patient with TRS and CRS, clozapine, if patient is not responding to clozapine, possibly ECT comes as number 1. Just to summarize what is there, how you need to go about. For positive symptoms, if you don't want to use ECT, that's what I'm just trying to clarify. If you just want to choose that agent, remember this table, that how you should be going about, and which antipsychotics which you should be using. Mainly the data is supporting amisulpride and aripiprazole, both for positive symptoms, negative symptoms, mixed symptoms, and also but for suicidal ideations, you need to prefer a mood stabilizer or an antidepressant. And for aggression, valproate and amisulpride are being reported to be used. With this background, let's try to understand how do we need to go about managing a patient with CRS. So first, ensure that you have given an adequate trial of clozapine in terms of dose, duration, and adherence. Ensure that you have given the maximum tolerable dose. Then the most important thing that you need to question yourself, can I increase the dose of clozapine further? What is more safer, increasing clozapine further or adding a second agent? I usually prefer to increase clozapine as much as possible before I think about adding something else. In terms of level of functioning, so this is important again. Remember that don't decide about your treatment, augmentation agents and everything based on psychopathology severity only. Look at the functioning in terms of occupational functioning, in terms of psychosocial functioning. If it is fine, question yourself, is there a need to augment? Patient with positive symptoms, they are still able to manage their functioning. There may be no need to augment, because if you are thinking about augmenting, you are also giving more side effects to your patient. Then consider various treatment alternatives in the form of psychosocial interventions before you prescribe an additional agent, because in Indian setting, our patients have a lot of financial resources problem and other things. So a lot of psychosocial issues persist, to try to first look at that. And if they are Are these contributing to ongoing psychopathology? And can I manage the psychosocial issues with psychosocial intervention before augmenting with any agent? Once you have decided that you are going to use multiple augment, before you add an agent, think about that if the patient is already on multiple medication, actually the whatever you're thinking the patient is not responding to clozapine may be actually due to polypharmacy. So is there a merit to stop polypharmacy, reduce the agents, and first see what is the level of severity of the patient? Because that is again important. A patient who is already on 2 antipsychotic, not necessarily that you add a third antipsychotic or don't stop the second antipsychotic and do a cross taper of the second. That is something which may not be recommended. So overall, evaluate the drug load, try to reduce the drug load. Remember, complicated prescriptions can actually cause medication adherence problem, and patient may not understand, they may not take medication. Always check all the medication which the patient is taking. Many times you have prescribed something, but patient is getting something, and whatever the dose you have told patient or mother, family members have not understood that. In addition to that, check for the over-the-counter medication, cultural remedies, herbal remedies, and illicit drugs, and so forth, so that you understand what other factors are contributing to CRS and what you need to address first. And evaluate the patient's current adherence to treatment before adding any other medication. Always assess the patient's paying capacity, because if you just keep on adding medication, it may happen the patient will not take clozapine but may take the augmenting agent because he thinks the newer drug is going to work. So that is where you need to keep that in mind. And if you are augmenting, always increase the frequency of follow-ups and time spent with the patient to understand the psychosocial issues and try to address that. So what we need to remember, and when you're choosing a drug, the symptom profile, what the patient is having, look at the psychiatric comorbidity, physical comorbidities, drug interactions, and the past response to the same agent. Maybe if you want to give a second antipsychotic, if patient has responded to a certain extent to olanzapine or risperidone, it may be better to combine that rather than thinking about aripiprazole or olanzapine. Then have good knowledge about the pharmacokinetics and pharmacodynamics, drug interactions, and the additive side effects, so that you are able to manage patients better. And always define the kind of response which you are expecting from a new agent. When are you going to say that my patient has responded, and when are you going to say that he has not responded, so you are prepared to discontinue the newer medication? And educate the patient for how long the newer medication is going to be given, what is to be given, and what effect, positive and negative, can emerge. And whenever you are changing medication, change only one medication at a time, so that you are very clear what is working, what is not working. And because you're doing augmenting therapy, start low, go slow. Remember about the drug interactions, and cross taper initiated in between should not be left at that you stand in the mid road and don't continue the cross tapers. And if patient has not responded to agent, discontinue it. And the maximum duration of an augmenting agent needs to be remembered should be 3 months. And while using ECT, remember that clozapine reduces seizure threshold. So, and clozapine itself has high anticholinergic properties, so it can precipitate delirium. So always look at all the medications which have high anticholinergic properties and try to reduce while you're giving ECT. While giving ECT, you can reduce the dose of clozapine and then later come back to the higher doses which the patient was tolerating earlier. And in terms of post-ECT delirium, when you're using bilateral ECT with higher stimulus for longer seizure duration, that is where you will see more clozapine-related delirium. So what I said, that reduce the dose of clozapine while giving ECT, stop the medication which can be stopped, and monitor the patient for prolonged and the tardive seizures. So to conclude, how do we need to go about for positive symptoms? You may think of adding a second antipsychotic or ECT. For negative symptoms, again, amisulpride, ziprasidone, mirtazapine. For general psychopathology, adding a second antipsychotic or valproate. And for depressive symptoms and cognitive symptoms, you can use antidepressant and memantine. And for OCD, again, you can use antidepressants. But again, you need to remember what are the other additional benefits you can have. For example, if you're using higher doses of clozapine, adding valproate may be beneficial because it will reduce the risk of seizure. Similarly, may be true for lamotrigine. And fluoxamine can be useful in increasing the serum clozapine levels, or can reduce the serum triglyceride levels if you're facing metabolic side effects with the use of clozapine. So to conclude, about 30 to 70% of patients with TRS do not respond to clozapine. And before considering that patient has not responded to clozapine, a proper adequate trial of clozapine should be ensured. And at present, there is limited data to suggest what will work in patients who do not respond to clozapine. That's why we need to properly define the symptom domain and before we choose the agents. Among the various augmenting strategies, possibly ECT appears to have the best evidence and more beneficial, but because of the stigma associated with and Western people not recommending it, it's not getting the higher kind of recommendation. So these factors needs to be taken into account, and the contextual factor must be taken into account before you choose an agent to augment clozapine. Thank you.
Thank you, Dr. Sandeep, for this insightful rendition. And before I speak something, I'll request Dr. Hina if she has, her comments to make. Dr. Hina, over to you.
I thank you so much, sir. I think there was so much that even I learned today. I'm sure there will be many questions for you. So I think without wasting much time, I think we'll just take up some questions and answers. Well, I don't see any except for my comment and Dr. Nishant's comment. So everybody has probably followed everything. Okay. Yes, sir. There's Dr. Rajesh Nehete. He's written that thank you for an excellent presentation. However, there is a limited advice in literature on management of clozapine fast metabolizers. What is your advice for the dosage, stroke plasma levels for fast metabolizers?
See, in the fast metabolizers, it is important that you increase the dose of clozapine because they can tolerate higher doses, and try to ensure the minimum 350 nanogram per ml levels. So in that case, the higher doses may be tolerable by those patients, so that you need to understand that. Otherwise, many times like adding an inhibitor like fluoxamine may be beneficial. But again, you need to understand the game of clozapine versus norclozapine and what works and what doesn't work. So that knowledge has to be very clear when you understand in using clozapine in fast metabolizers.
Dr. Alia has written that thank you, sir, for a wonderful presentation. You've covered everything. There is a question by Dr. Rajesh Nehete. He says that he's gone a maximum up to 950 milligram. Would you advise more than that?
See, the recommended dose for clozapine I said that to achieve minimum therapeutic doses for Indian population is a maximum is about 300 milligram. And to my experience, I have seen one patient who came to me from USA receiving 900 milligram. My own experience, maximum dose which I have gone is about 700 milligram. So I will not say that I have an experience of using that higher doses of 950 or more than that. My maximum experience remains at 700 milligram. I've seen only one patient on 900 milligram coming from US, and I presume that he was a very, very fast metabolizers. I would not recommend going beyond. But remember, if totally it will depend on the tolerability. If the patient is tolerable, maximum recommended dose is about 1000 to 1200 milligrams. So that you can try.
So there is also a question that cannabidiol and clozapine resistant schizophrenia, will it worsen or will it be used for treatment?
At present, we do not have any data. Theoretically, cannabis can worsen psychosis, so that needs to be kept in mind at this moment. Once the data emerges, we don't know what data will emerge, because here the cannabis doses which will be given will be of lower doses, so we don't know at present. Because now the lot of relationship of cannabis and schizophrenia is seen to be dose dependent, and the quality of cannabis. So all these things will come in the near future. We'll get answers to this question.
There is another question which says about role of cariprazine in clozapine augmentation.
Yeah, again, some data is emerging for use of cariprazine, mainly for combining with clozapine in terms of negative symptoms. But again, not very robust. The data is like any other antipsychotic. So but my own experience of using cariprazine, that it leads to a lot of EPS. So you need to keep that in mind, because many patients end up receiving clozapine because of tardive dyskinesias and intolerability to other antipsychotics. So if the patient has that kind of a history, you should be very careful in using cariprazine.
There is a question which is about the role of ECT. I think Dr. Abdullah, I think sir has spoken extensively about where ECT should be used and in what. Sir, but if you would just like to just say a few comments or maybe some takeaways.
Yeah, maybe sum it up.
Yeah. Like at our center, or I should say with my experience, the patient's positive symptoms are not responding to clozapine, and we have given an adequate trial, we always prefer to give ECT. That's the first kind of a thing which we try. and if the patient does not respond to ECT or responds to ECT. If patient responds to ECT once and is again having relapse, now our own experiences, we put the patient on continuation and maintenance ECT. So in fact, we have just published the data on continuation and maintenance ECT in IJP this 2-3 months back only, where a lot of data of this CRS group patients was there. So remember that it's not just an acute course of ECT, but some patient may end up requiring long-term continuation and maintenance ECT. And you need to remember this, it may be beneficial combining rather than combining two antipsychotic, but with ECTs, you are not giving that much of side effects to the patient. And for the continuation ECT, the protocol which we follow is after the acute course, first month, 4 ECTs once a week, next month, 2 ECTs once in fortnight, and after that, once a month for next 6 months. So that's the kind of protocol we follow. And remember, while using ECT, remember that normally you talk about 6 ECTs in patient with depression or mania, but for CRS, when you're using ECT, it is about 11 to 12 ECTs.
12.
That is what you need to remember for acute course. Yeah.
So Dr. Grover has already answered the question on frequency of ECT. So that was a question which was directly posted from the YouTube channel.
Okay.
So there is another question which says that how do you manage my God, it's going so fast. How do you manage clozapine-resistant schizophrenia if patient develops clozapine intolerance later during the course of the illness? Should we reduce the dose or stop clozapine and add which other pharmacotherapeutic agent instead of clozapine?
See, again, when we talk about clozapine intolerance, you need to understand that if patient is not tolerable, the first strategy is always to get down to the dose which is tolerable. So that is a common practice. Now, what happens, what the condition which we are talking about, when you are increasing clozapine, patient is not tolerating. So in that case, remember to increase the dose of clozapine slowly. That is something which we need to remember. Clozapine is not a drug which you should be increasing very fast. Many times when you increase clozapine doses very fast, patient will not tolerate. So in that case, I would say that depending on the severity of symptoms, whether you can wait and watch, you can reduce, both can work depending on whether the patient is inpatient, outpatient, and what is the intolerability. Intolerability can mean agranulocytosis also. Intolerability can mean sedation also. It can mean constipation also. So you need to understand, we've been talking about intolerability, the common side effects. If your patient is experiencing, you can wait and watch. But if the life-threatening side effects are there, you need to maybe stop clozapine.
So Dr. Shikha Adil wants to know that with regards to ECT and CRS, does the electrode placement, that is bitemporal or bifrontal, has anyone in difference in terms of improvement?
Again, in general, because we do not have any data to compare the same, I will not be able to comment on that. But in general, we know that bitemporal ECT is more effective. So when we talk about experience from depression or mania, when unilateral doesn't work, bifrontal doesn't work, you go to bitemporal. But that's what. But we do not have evidence to say that this works better. So maybe who's asking the question, they can generate more evidence. It will help to everybody to learn. Yeah.
So there's a question which says that is clozapine blood level monitoring available, and what's the procedure to do it?
Okay. So clozapine blood levels are available. Are at present in the one private lab which is doing it in Bombay. It is available in NIMANS, and at PGI we have also developed that level. I'm not sure about CIP, so Nishant can update me that. So these are 3 places I am aware of, and the levels, again, different kind of parameters are being evaluated. Trough levels, or you want the peak levels. The trough levels are usually again evaluated like lithium after 12 hours of the last doses, and usually it is collected in the so-called cold chain containers, and it is shifted to the lab, and then you go about. So you need to maintain that cold chain to get the levels done properly. Yeah.
So this is a very interesting comment. Is clozapine resistance equal to something serious in chronic psychosis, or it's just our bias about Kane and his observations?
Okay. Now, what we need to understand that I will answer this question in a reverse direction. Actually, people have a lot of negative bias towards clozapine, that they don't start clozapine in right time to the patient when actually 2 antipsychotic trials are failing. So it's not a so-called positive bias towards clozapine. It's a negative bias towards clozapine, which previous literature around the world has shown that many patients who require clozapine are actually not started and if it is started, it is delayed. Our data suggests that it was delayed by about 1.5 years in India at our center at one time. Now we have reduced it to wherever it is possible. What we need to keep that in mind, because there is a lot of data to suggest that if clozapine is indicated and if you delay by about 3 years to start, then patient is actually not going to respond to clozapine. So we should not harm our patient. If you're not starting clozapine, from my perspective, you're harming your patient.
So Dr. Jigisha would like to know that how to deal with clozapine related cardiac problems or precipitation of a previous cardiac disease and possibilities of a sudden death while augmentation with clozapine. In some chronic closed ward patients, mostly wandering type, previous cardiac diseases are not known and ECG will be normal while starting. So kindly shed some light on cardiac complications in high doses.
See, whenever you are using clozapine, if you go by the baseline recommendation, how to start clozapine, that can itself be a another talk which I can do it next time, maybe if you feel so. But we need to understand, it's not just ECG which is sufficient. You need to get the CRP levels, you need to get the cardiac markers levels done. And you should always, if you think there's an underlying cardiac disease, you should always get an echo done before you start clozapine. And one of the important things which you need to remember is if patient is having tachycardia during the initial phase of clozapine therapy, that is a so-called an indicator that cardiac problems may arise. So you should closely monitor patient having tachycardia and then do the cardiac markers and look at things. The other thing is when you're looking at hemogram, we always talk about total leukocyte count and neutrophil, and we often ignore eosinophil count. Look at the eosinophil count. Eosinophil counts can always give you, they are considered to be precursor marker of coming any kind of inflammation, like it be myocarditis, pancreatitis, hepatitis, and everything. So remember, if you remember certain things, you'll be able to predict certain things. So no harm in getting the CRP levels, cardiac markers as required, and when you're doing routine hemogram, always look at the eosinophil counts.
So Dr. Gormode would like to know that how to assess for improvement and need for further ECTs. Should we assess after 4 ECTs or go for further more and then assess?
Okay. See, there are two ways to answer that question. When you are starting acute course of ECT, you assess at baseline, then assess at the end of the ECT course. Now, that's the first ECT course which you have done. At the end of the ECT course, if you have determined, and then you are stopping ECT and waiting and seeing what happens to the patient. There are two courses which the patient can follow. One is he's not going to relapse anymore, or he's going to relapse. Once he relapses, now you are thinking about a maintenance treatment. So when you're talking about maintenance treatment and you're starting the second course, which will be followed by the continuation maintenance ECT, you should not worry much about the improvement. Now you are maintaining the improvement. The basic aim is what you achieve at the end of the ECT course, you want to maintain that. It is only when you're still not able to maintain, that is where you have to determine the frequency of ECT and other things. So once you're going to that maintenance, like when you add a second antipsychotic, when you say patient has improved, then your job is to maintain. You don't change the second antipsychotic till the patient is maintaining. The same remains true for ECT.
So clozapine itself can increase positive symptoms in cases of associated obsessive compulsive symptoms and chronic psychosis. What nomenclature can be added to this? Should it be called as clozapine resistant schizophrenia or clozapine exacerbated hallucinations?
Okay. Now, this is what you need to understand. This is again I would say myth. Let's first understand when I use this word. People, those who are receiving clozapine, if you don't monitor their psychopathology properly and don't ensure adherence, as soon as you stop clozapine, patient is going to experience what is known as supersensitivity psychosis, which again I can have a talk sometime later. As soon as the supersensitivity psychosis comes in, patient is seen to having worsening of psychosis, which is actually worsening is occurring because of poor adherence. And in some people, worsening can occur because of supersensitivity psychosis overall in their course of illness. So that is not a worsening due to clozapine. So before you say it is worsening due to clozapine, you have to be 100% sure that patient's adherence is 100%. So that is where this whole myth comes in.
I think, sir, just wanted to pitch in between. When you were talking about ECT in clozapine-resistant schizophrenia, I just wanted to inform you that we are running a multicentric randomized control trial, NIMHANS, CIP Ranchi, and KMC Manipal, where we are actually doing bitemporal ECT in clozapine-resistant schizophrenia, and we are the only trial in the world which we are using sham ECT also. So it's basically active ECT versus sham ECT, and this trial is still going on, so I cannot share the findings yet. We have a total sample size of 120 cases across 3 centers, sir. So maybe if we are able to get these many patients and we are able to get these many findings, many things can be, we can think about talking about many things which you have spoken today, sir. Over to you, sir.
The open label trial which we published had about 65 patients.
Yeah.
And those were CRS patients. Because we run a clozapine registry.
Yeah.
So we have a clozapine registry. We are trying to maintain our patient of CRS and TRS so that we are trying to give them as good care as possible.
We have Dr. Srihari Prakash. Sorry, Dr. Nishant.
Yeah, I think, ma'am, we are coming close to the end of today's.
Yes, I was just about to say. Maybe so. Just one comment that from Dr. Srihari Prakash. He says that he was very glad to have attended your seminar, and as always, Dr. Grover sir's lectures are great.
Thank you.
So I think with that, with permission of my co-chair, we could
hand over. Yeah. Over to you, Rukshida, if you're around. Rukshida?
Yes, I'm around. Nishant, some few words of wisdom from you.
I think I've already shared my words of wisdom. Working in a standalone mental health establishment, getting such cases, it's a big issue, and we do face a lot of problems, particularly when patients not only not responding to clozapine, but also developing significant side effects. So many comments made by Dr. Grover today and many questions which were raised in the crowd were very, very pertinent. My question will always remain to Dr. Grover. I keep on asking him, like if I come across a patient with early onset schizophrenia, what is the status of clozapine and how clozapine is going to, when I'm talking about early onset, I'm talking about schizophrenia starting at the age of between 13 to 18 years. And we do get a lot of patients, in our center at least. So sir is smiling, and I think you have something to say about it.
Don't blink your eyes. If patient fulfills the criteria of TRS, start clozapine as early as possible.
So I knew that you're going to tell me this, and we are following that. Thank you so much for today's deliberation. It has definitely made all of us wiser. Thank you very much, Team IABP. I am part of Team IABP, so I can say and thank Rukshida and Majid Bhai for giving us this opportunity. Over to you, Rukshida. We can conclude the session after vote of thanks. Over to you, Rukshida. Thank you.
Thank you. Thank you so much. I think one of our best attended sessions today, and all thanks to just the name Sandeep Grover, not only just on the Zoom platform here, but we've also had a lot of viewership on the YouTube channel as well. Of course, this session is going to be uploaded there for further learnings. IABP First Friday Semis generally attracts a lot of young psychiatrists and PG students, and when we have such a clinically relevant topic delivered by such a clinically relevant professor, I think that that just goes to that there's no stopping us then, isn't it? And it just struck me that I've known Sandeep for a while. We were World Psychiatry Association Young Fellows together. That's when I first met him, and now it seems, oh my God, that was ancient. I will not say how many years ago, because that I don't care, but Sandeep would not be very happy with me, but it was a long time ago. So thank you so much, Dr. Grover, for gracing us with your presence and sharing your knowledge, all for the service of biological psychiatry. On behalf of my entire team of IABP, I'm really, really grateful to you to taking time out. You agreed to it while you were even out of out of the city on a holiday. So that's especially very, very kind of you to take the time off from your holiday just to even decide that you're going to do this. So thank you so much for that. And my two very special chairs, Dr. Nishant Goel and Dr. Hina Merchant, thank you so much for being here with us and helping the session progress so well and guiding all of us so well. With that, I bid you all good night, and hopefully we will see you again next month for the next episode of First Friday CMEs. Thank you so much. Good night.
Good night. Thank you.
Thank you, everyone. Have a good evening.